Hello, friends. So today I'll be talking on this pneumococcal disease prevention in adult population. So this talk I gave it during GIGS conference on the second day. So I'll give you an overview on the importance of vaccinating adult population for this pneumococcal. So as we understand, as medical professionals or doctors, we are also very vulnerable in having pneumococcal infections because of the nature of our work and the risk of exposure that we have. So even we need protection. So that is the backdrop that we should be looking at. So, and it has been very clearly shown that the healthcare workers are more susceptible to infections because of the obvious nature and our exposure to the infected patients. And it is shown that healthcare professionals are vulnerable to develop pneumonias, and predominantly it will be the influenza or pneumococcal pneumonia. So this has been shown to be more common in healthcare. And this leads to a lot of absenteeism of healthcare from the work. I'm sure most listeners would agree that flu or the common flu is a common reason why we get unwell and we may have to remain absent from the work. And this obviously will have a bearing on reduced productivity at the work and reduced efficiency. Obviously, when you have flu symptoms, you would be groggy and you wouldn't be able to function to your optimal levels. And this may impact, and the studies have shown this has possibly an impact on the patient care also, because when there is absenteeism, there is less staff and the care to the patient would be compromised, and the quality sort of a care that is expected from the healthcare professionals can be compromised. So this is the sort of backdrop that one needs to bear in mind. So this was a study from Russia where they shown that vaccination with pneumococcal conjugate vaccine. So throughout my narrative, I'll be using this word PCV 13, which is pneumococcal conjugate vaccine 13 in healthcare workers. So this was a study that came from Russia in 2019, whether it was effective in healthcare workers to reduce pneumonia. And it was shown that the incidence of pneumococcal infections was reduced by 2 times in healthcare workers. And the respiratory infections also was reduced by 2 times. And asymptomatic carriage was reduced by 2 times. And the overall respiratory infections reduced to 33%. So which is a good enough study to tell us that healthcare workers getting vaccinated with pneumococcal conjugate vaccine has shown reduction in the occurrence of respiratory infections. So now we cannot obviously forget COVID and its association with strep pneumonia. So there are studies to indicate that someone with COVID infections are vulnerable to develop strep pneumonia co-infections. So this was a study from Spain that came in 2021, where they looked at 989 COVID patients, and they saw co-infections with strep pneumonia or co-infections with any infection happened in 7.2%. 88, they identified 88 infections in COVID patients where they had other co-infections, out of which 74 were bacterial infections and 57.1%, the 74 were strep pneumonia. So strep pneumonia seems to occur more commonly amongst the bacterial infections that happen as co-infection in COVID patients. That is what we need to bear in mind. And fungal happened in 7 patients out of the 88 infections, and viral co-infections happened in 7. So which means predominantly the co-infections in COVID appears to be a strep pneumonia with regards to bacterial infections. So now, is there a advantage or a benefit in giving pneumococcal conjugate vaccine in patients who had a COVID? So this was a study again by US where they shown patients who have had COVID. It was shown that administration of this pneumococcal conjugate vaccine showed 32% lower incidence of having COVID hospitalization and 32% lower incidence of COVID death. So which means to say someone who is vaccinated with pneumococcal conjugate vaccine, even if they get COVID, the risk of hospitalization and the risk of death was significantly shown to have reduced, which means to say because of the co-infection risk in COVID, so it is imperative that having a pneumococcal conjugate vaccine and protecting them from other infections. And I would go to an extent saying having pneumococcal vaccination along with a flu vaccination or influenza vaccination will offer more protection as opposed to not being vaccinated and being exposed to COVID. So that is something that one needs to. So having a shield for pneumococcal infections, having a shield for influenza virus, and having COVID vaccination seems to be more beneficial in reducing these respiratory tract infections is what we could decipher. So now, obviously the question that would come to one's mind is, if someone has had a COVID vaccination, how quickly can they have pneumococcal conjugate vaccine? So the Ministry of Health of Government of India suggests that after COVID vaccination, 14 days later, they can get pneumococcal vaccination. So you only need 2 weeks separation for getting pneumococcal vaccination as per our government regulations. And the pneumococcal conjugate vaccine for strep pneumonia is approved in India for all these age groups. So as you see, this vaccine is considered safe in all age groups, 6 weeks to 5 years. And in fact, this middle age group was not approved. Recently, that has got approved. So the recent approval has happened even for healthy age group, which is 18 to 49 years. And this is also, so basically, this vaccine is safe across all age groups, starting from 6 weeks to more than 60 years. So we look into, this is the landmark sort of an article that came from from CMC Vellore, where they looked at what is the risk of someone developing invasive pulmonary disease and what is the association of mortality with strep pneumonia. So this was a prospective surveillance study done over 15 years from 1993 to 2008, done in 7 hospitals. 449 patients, more than 18 years, they took who had invasive pulmonary disease. So they looked at 1,037 patients, out of which 44.3% of the patients with respiratory tract infections had strep pneumonia. And the case fatality rate when someone has strep pneumonia infection or invasive pulmonary disease is 25 to 30%, so which is a reasonably high mortality. And if you look at strep pneumonia causing problems, this is the sort of findings they found in the study. 36.9% had meningitis due to strep pneumonia. 36.6% had sepsis secondary to pneumonia or any other site of infection. 20.8% had invasive pneumonia, and 26.4% had other infections. So which means to say it can cause serious problems. Strep pneumonia can cause pneumonia, sepsis, meningitis also. So it is not a simple bug, and mortality can be sitting up to 25 to 30% is what one needs to bear in mind. And what are the clinical presentations? So any pneumococcal disease, you can divide into 2 broad categories. One is non-invasive pneumococcal disease and invasive. In non-invasive, we all understand it can cause simple URTI or it can lead to LRTI, and pneumonia can be threatening. And invasive, it can cause bacteremia, meningitis, other disease. And invariably non-invasive, if it is not adequately treated, it can lead to invasive or vice versa. So that is something so it is not a simple thing. So strep pneumonia, especially if it happens in someone with multiple comorbidities or any organ dysfunction like CKD, liver dysfunction, diabetes, smokers, ethanol, it can lead to invasive problems and it can be life-threatening with mortality going up to 30% is what we need to bear in mind. So this was a big study that came from Korea called ANSORB study, Asian Network for Surveillance of Resistant Pathogens. This was done in 60 hospitals in 11 Asian countries. They looked at 2,184 strep pneumonia infections, and they found 80% of the infections caused pneumonia, as opposed to the Vellore study where it showed meningitis appeared more common, followed by pneumonia and sepsis. Here, this ANSORB study, which is the landmark, possibly more bigger study done by South Korea, 80% caused pneumonia, 4.9% caused meningitis, and 3.2% caused bacteremia, and 11.9%. So I think for all the listeners, we can think strep pneumonia, as the name suggests, predominantly causes pneumonia, and 25 to 30% is the mortality, more so in patients with comorbidities. So that is where our whole focus would be. And in this particular study, 80% of the patients who had pneumonia went on to develop bacteremia in 13.8%. So what about the risk, whether the pneumococcal has an associated risk with underlying comorbidities? Yes, the answer is yes. Again, this Korean study, the ANSORB study, showed that patients who have an underlying lung disease are at a higher risk. 20.4% of them developed strep infections, and 13.6% with underlying diabetes developed. And even someone with underlying cardiac disease and chronic renal disease are at a risk of developing strep pneumonia. As you see, diabetes and having underlying lung disease like COPD, bronchiectasis, or interstitial lung disease, they are at a much higher risk of developing strep pneumonia infections. And what about the age? So this was a study from Sweden, which shows there is a sequential increase in the risk of strep pneumonia with increasing age after 50 years. As you see, after 50 years, there is a sequential increase in the risk of them developing strep pneumonia, or in the pediatric patients in less than 1 year, they are at a higher risk. So extremes of age fall under a high risk category of developing strep pneumonia infections. And whether there is a correlation with the age and death rate, as you see, this study is done by CDC in US, shows that as the age increases, the risk of having strep pneumonia increases, and so is the death rate. And there is a good correlation between the increase in the risk of them developing strep pneumonia and the increase in the death rate. And this is a very important aspect I wanted to touch. And we see in our ICU very commonly that patients come with heart failure. And many a times we treat them as heart failure, they don't get better. And very often we believe they possibly may not have had a background cardiac problem. And eventually we realize they would have had a LRTI, which would have worsened sort of a heart failure symptoms, or they who otherwise have not had a background cardiac problem, but they do present with heart failure symptoms along with LRTI. We see that's very common. And so this is something which I want listeners to pay attention, that the fact that someone has a strep pneumonia infection itself puts a stress on the heart, and they can present with some sort of heart failure symptoms. It can be diastolic heart failure. And this has been shown. And this has been shown in this study where pneumonia increases the stress, possibly reduces the blood pressure. And the fact that they have strep pneumonia has a correlation in someone developing acute coronary syndrome, developing arrhythmias, or even heart failure. This has been shown. So this is something which possibly listeners should bear in mind. Someone presenting with heart failure, they may have a concomitant infections which may have triggered, and that has been shown in the study. And this study from US has shown that someone with strep pneumonia can have new onset of worsening heart failure, as you see in 14%, and new onset arrhythmias occurred in 5.8%, and even MIs happened in 7.1% when they've had a strep pneumonia infection. So which goes on to show that it is not a simple lung issue. So once they have a strep pneumonia infection, there is a concomitant increase in the risk of them developing cardiac events, is what I want listeners to just bear in mind. And now we'll move to the topic as to how do we prevent pneumococcal. So the World Health Organization suggests prevention is the best way to avoid this pneumococcal and its associated morbidity. And they have put that as a high priority, and both in industrialized and in the developing countries. So now we look into the vaccination. So how did the whole pneumococcal vaccination evolve? So when you look at the evolution of pneumococcal vaccination, so initially there was only pneumococcal polysaccharide vaccination, which is called PPV. Until 1983, we had only pneumococcal polysaccharide vaccine 23. So after 83, there was development of pneumococcal conjugate vaccine. So here we are here to understand what is the difference between pneumococcal polysaccharide vaccine and pneumococcal conjugate vaccine, and whether there is an advantage of giving pneumococcal conjugate vaccine over pneumococcal polysaccharide vaccine is what possibly we'll have to understand. So when you look at polysaccharide vaccine, so you have these B cells. So this is the polysaccharide. And here there is, once patient gets infected with pneumococcal, there is a differentiation of B cells which happen without something called affinity maturation, which leads to, so the main protection comes from these plasma cells which produce antibodies. And it is shown that polysaccharide vaccine leads to production of antibodies which have low affinity, and only it leads to production of IgM and IgG2 with no class switching. So this is something which is unique to polysaccharide vaccine. So just pay a little attention. So there is a differentiation without affinity maturation, and low affinity antibodies are produced by this plasma cell with no changing or changes in the sort of a variety of the antibodies. So there is no class switching that happens. And B cells here with polysaccharide vaccines, there is no sort of a concomitant production of T cells. So the B cells act independently. So there is no activity of B cells in tandem with T cells. And there is a depletion of memory B cells, and there is no new memory B cells. So we have understood from COVID how important is the presence of memory cells, because memory cells are needed for long lasting immunity. Because if there are no memory cells, then the immunity conferred by any vaccine is short-lived. So this polysaccharide vaccine leads to short-term immunity, which is not long-lasting, because memory B cells are depleted and there is no production of new B cells, and B cells act independently without T cells. That is what is the limitation of polysaccharide. So we look at pneumococcal conjugate vaccine. In conjugate vaccine, there is a polysaccharide which also has a protein carrier, and here B cells work in tandem with T cells. So they act in conjunction with T cells, and there is differentiation with affinity maturation. There I said differentiation without affinity maturation. And here they produce high affinity antibodies, and there is a class switching that happens in the antibodies, and there is increase in the memory B cells. That's why the immunity conferred by the pneumococcal conjugate vaccine is much longer, much long lasting because of the increase in the memory B cell production that or memory B cell results that happens. So this is the key difference in conjugate vaccine. So what are now the audience should have a question. So are there any trials on PCV vaccine? Yes, there are 3 landmark clinical trials on pneumococcal conjugate vaccine. One is the CAPITA study that came in NEJM in US group. Then there's a Louisville study. This CAPITA study looked at the effectiveness of PCV, pneumococcal conjugate. Louisville study looked at whether by giving pneumococcal conjugate vaccine, whether there was reduction in admission into hospital in elderly population. Then there was a pivotal clinical trial, which again came by US group, which looked at the safety and immunogenicity of the PCV vaccine at 18 to 49 years. So we look very briefly into CAPITA study. So CAPITA study showed there is reduction in pneumococcal disease by 46%. It prevented first episode of vaccine type pneumonia, and there was a 45% reduction in the first episode of non-bacteremic and non-invasive pneumococcal infection, and 75% prevention of first episode of vaccine type invasive pulmonary disease. So this CAPITA study showed that pneumococcal conjugate vaccine was very effective in reducing the first episode of vaccine type pneumonia and invasive pulmonary disease also. Then Louisville study, which looked into whether vaccine was effective in reducing hospital admission, showed there was 73% reduction in against hospitalization. So vaccine efficacy was at 73% in reducing hospitalization for vaccine type community acquired pneumonia and against non-bacteremic vaccine type community acquired pneumonia. So there was a significant reduction in hospitalization for vaccine type community acquired pneumonia in this particular study. So now what are the recommendations? So the pneumococcal conjugate vaccine recommendation comes from KDIGO guidelines, which is for the kidney failure patients. And there is advisory committee for immunization practices. They also suggest and recommend PCV vaccine to be adopted. And the GOLD guidelines is the Global Alliance for Obstructive Lung Disease. They also suggest that PCV has to be incorporated as a standard of care. And American Diabetic Association also recommends the usage of PCV vaccine for elderly patients. So now the question is, what is the recommendation? So ACIP is the advisory committee for immunization practices. So what is the advisory committee recommends? It recommends that more than 65 years, pneumococcal conjugate vaccine PCV13 has to be given. And after 1 year, then you can consider giving pneumococcal polysaccharide vaccine, because this is as a booster dose. But 1 dose of pneumococcal conjugate vaccine is needed. Suppose if someone has received PPSV, which is pneumococcal polysaccharide vaccine, even then after 1 year, one has to administer pneumococcal conjugate, because pneumococcal conjugate vaccine is shown to give longer immunity because of the increase in the memory B cell pool. Or if someone has already received pneumococcal polysaccharide vaccine less than 65 years, they have to wait for more than 1 year. If they cross 65, pneumococcal conjugate vaccine has to be given more than 65 years. So this is the sort of a ACIP recommendation, which means the simple way to remember is any patient more than 65 years should have got PCV vaccine, pneumococcal conjugate, irrespective of whether they have received pneumococcal. If they have received pneumococcal polysaccharide vaccine, wait for 1 year, but administer pneumococcal conjugate vaccine is what the recommendation is. So that's a recommendation. So, and the updated recommendation of the advisory committee is PCV13 should be given for more than 65 years in all patients, especially where if they are in contact with the pediatric population, because it's all to do with the herd immunity also. If they're in contact with pediatric population where this routine practice of giving PCV is not there, so they have to be given. Or if they are traveling to a place where there is no PCV being administered to pediatric population, they are at a higher risk of developing pneumococcal, so it needs to be given. Or in an elderly long-term care center or rehab centers, PCV 13 has to be administered. Or someone with a smoking history, ethanol, or someone who have an underlying cardiac disease, lung disease, or someone who have a liver dysfunction, diabetes, or a chronic kidney disease, all these patients are at a risk of developing pneumococcal, and all these patients, irrespective of age, should be considered for pneumococcal conjugate vaccine 13. So the take-home message is it's available as this Prevenar 13. So PCV is immunogenic, regardless of prior pneumococcal, because prior pneumococcal is always the older variants are PPSV, which is pneumococcal polysaccharide. So irrespective of whether someone has received PPSV, wait for 1 year, and if they are at a risk, they should get pneumococcal conjugate vaccine. And pneumococcal conjugate can be given along with the flu vaccine. So there's no need to wait. So you can give flu vaccine along with pneumococcal vaccine. But ideally, the recommendation is first they should get a PCV, pneumococcal conjugate, if they're not received. And after 1 year, they should get pneumococcal polysaccharide vaccine 23, PPSV 23. And PCV 13 is absolutely safe, and it has been demonstrated by these studies which I just suggested, and well-established studies indicate that it is absolutely safe. So that's the overview of the vaccine. So hopefully there is a good clarity on usage of this PCV 13 in the practice, and most of our ICU patients would possibly fall into this category of having those risk factors, and possibly our discharge summaries from ICU based on the overview of this topic. We should possibly recommend the patients to get vaccinated at least more than 65 years, or patients who have all the underlying lung problem or end-stage organ dysfunction. In discharge summary, there should be a recommendation that they go and they get PCV vaccine, because the mortality sits up to 30%, and avoiding or preventing them having pneumonia with strep pneumonia goes a long way in saving more lives. That would be the take-home message. So thank you one and all. So I end with this beautiful quote: "So attack to nothing, connected to everything." So thank you one and all. You can visit my website www.drpradeeprangappa.com to rehear to this lecture. Thank you one and all.